This will be presented from Tanjavur Medical College, Neurology Department. And today the chairperson will be Professor Arunan, Professor of Neurology and head of the Department of SRM Medical College, Katangulathur. And I now request Professor Arunan to take over and conduct the proceedings. Professor Ravi Kumar, Professor and HOD of Tanjavur Medical College will be the moderator. Professor Arunan, you can carry on, sir.
Yes, sir. Thank you very much, sir. Thank you, sir.
Yes, sir.
Good morning,
yes, sir.
good morning, friends. Good morning, friends. First of all, I thank Professor VN sir very much for giving me this opportunity. And this forum has been on for a long time with a very successful reception from the postgraduates. It's very useful and it reminds us of our MIN days also. Without wasting time, I request Dr. Shraddha Kedaya from Tanjavur to start the presentation. It is an interesting case of peripheral neuropathy.
Thank you, sir. Good morning, sir. I'll be presenting an interesting case of peripheral neuropathy from Department of Neurology, Tanjavur Medical College. Presenting Mrs. J, who is a 58-year-old female who is residing in Tanjavur and is a housewife. She came with the chief complaints of pain in the left foot since 3 years, 3 months with cotton wool sensation, pain in right foot since 3 years, difficulty in using left leg since 3 years, and difficulty in using right leg since 6 months. Patient was apparently normal 3 years, 3 months back, who later developed pain in the left foot, which was initially in the dorsum of the foot, which was insidious in onset, progressive, vague in nature, which was continuous, and there was no radiation to the calf or the thigh. After 3 months, she also developed similar complaint in the right dorsum of the foot. This pain was not aggravated during coughing, sneezing, straining, standing, or walking, and it was not relieved during sitting, leaning forward, or lying down. And there was no history of any neck pain or backache. History of cotton wool sensation, which was present in the left sole of the foot, which was insidious in onset and static. There was no history of any associated pins and needle sensation, and she was able to appreciate hot and cold sensation, including the sensation in the perianal region. There was no history of any skin changes or sweating abnormalities. About 6 months after this onset of the pain, she developed difficulty in using left lower limb, which was initially started as insidious in onset, progressive, in the form of difficulty in lifting toes off the ground, which was followed by difficulty in clearing the foot off the ground about 3 months later. Over the next 6 months, she had difficulty in gripping the chappal and slippage of chappal with awareness in left lower limb. By the end of 1 year, she progressed to develop difficulty in getting up from squatting position. The weakness of left lower limb was associated with the thinning of buttocks, thigh, and leg muscles, with the flailness and twitching in the left thigh muscles. About 3 years after the symptom onset, she observed similar complaints in right lower limb, which was started as difficulty in lifting the toes and then difficulty in lifting foot, followed by difficulty in getting up in squatting position. However, this was associated with the thinning, which was confined to buttocks and thigh, not involving the legs, and there was no history of any associating twitching. There was no history of any difficulty in using upper limb or difficulty in turning in the bed or lifting the neck from the bed. There was no history of any associated head nodding, tremors on reaching out for the object, or unsteadiness while walking. There was no any history of any increased frequency to appreciate the bladder filling and voiding the urine completely. There was no history of any constipation. There was no history of any forgetfulness or behavioral disturbances, and no difficulty in appreciating smell, blurring of vision, drooping of eyelid, double vision, facial numbness. There was no associated difficulty in swallowing, nasal regurgitation, difficulty in shrugging the shoulder or pushing the foot back of the tongue. There was no fever or rash. There was no chronic cough or joint pains, no pain abdomen or chronic diarrhea. There was no loss of appetite, loss of weight. There was no drug or toxin exposure, no photosensitivity or skin changes, and there was no history of any accidental fall or. Coming to the past history, she is a known case of coronary artery disease and on treatment since 15 years with an history of any diabetes mellitus, hypertension, chronic kidney disease, tuberculosis, connective tissue disorders, skin or liver disease. There was no history of any cancer, chemotherapy or radiation therapy exposure. Family history, there was no neurological illness or the cancer or rheumatological illness in any of the family members. The personal history, she takes mixed diet with a normal appetite, sleep normal. She attained menopause about 5 years back and there's no history of any postmenopausal bleeding. The treatment history, initial 2 years, she was given a symptomatic treatment with multivitamins. In 2022 May, she was given the 15 days of oral steroids, initially as 20 mg and later as 10 mg, following which she had no improvement in symptoms. In between, during the course of the illness, there is no history of any IVIG or plasma exchange or immunosuppressant drugs given. So summarizing, initially the symptoms started as onset with pain in the left dorsum of foot, which was associated with cotton wool sensation, followed by pain in right dorsum of foot about 3 months later, and about 6 months after the onset of symptoms, there was left lower limb distal weakness, which over a year progressed to proximal weakness, and also since 1 year, there is a right lower limb distal as well as proximal weakness. So summarizing, there is a 58-year-old lady who presented with chronic, slowly progressive neurological illness of 3.5-year duration, which is asymmetric onset, bilateral pain in dorsum of the foot, which was followed by asymmetric onset flail weakness of lower limbs, started as distal, progressed to proximal weakness with no involvement of truncal or upper limb, which was associated with thinning and twitching of both the limbs, left lower limb more than right lower limb, with no involvement of bowel, bladder, cranial nerve, autonomic nervous system, cerebellar system or higher mental function or systemic symptom. So coming to the symptom analysis and the structures involved.
So can you wait? Shall we ask someone else to discuss?
Yes.
Anybody from your college or some other postgraduate there? Anybody interested in discussing? Nobody. Okay, you start discussing. You give your summary.
Yes. The summary is 58-year-old lady with a chronic, slowly progressive neurological illness of 3.5 years duration, which initially started as a pain in the dorsum of the foot left, followed by sequential involvement of both the right dorsum of the foot, which was followed by asymmetric onset flail weakness of left lower limb followed by right lower limb, which progressed from distal to proximal weakness, which was associated with the thinning and twitching, with no involvement of truncal or upper limb muscles. This was the progression of disease in our patient. Can I discuss, sir?
Yes, rather you discuss symptom analysis for both sensory and motor phenomena.
Yes,
Then
sir.
you localize according to the sensory and motor. Where is the lesion?
Yes, sir. So initially the patient symptom is pain in the left dorsum of the foot, which was associated with a cotton wool sensation in the left sole of the foot. Now this pain can be either L5 radical or a peroneal nerve. Now and also it can be a musculoskeletal pain. However, here I would like to localize it to the peripheral nerve, that is to the peroneal nerve, because it is a aching type of the pain which is vague in nature, and L5 as a second possibility, but still points against L5 radical is there is no radiating or shooting of the pain, and it is not aggravated with any variety of provocative manners like coughing, straining or sneezing. And it is associated with a cotton wool sensation in the sole of the foot. So possibly it may be involvement of a tibial nerve or a S1 radical. This pain was not associated with any of other positive symptoms like pins and needles, or it was not associated with inability to appreciate hot and cold or cloth sensation. And after this onset of pain, about 6 months later, she developed left lower limb weakness, which initially started as difficulty in lifting the toe from the ground, which indicates that there is a weakness of the toe extensors, which was followed by difficulty in lifting foot off the ground. which suggests that there is a weakness of dorsiflexion of the left foot. So probable structures involved may be again either a peroneal nerve Now, difficulty in getting up from squatting position indicates that there is a proximal muscle weakness, probably a gluteus maximus muscle, that is hip extensor, which can be, so the structure involved may be either an inferior gluteal nerve or a S1 radical. Now, this weakness was associated with the thinning of thigh muscles, leg muscles, and calf muscles, which was associated with the twitching in the thigh muscles. So for these symptoms, I would think of either it is a polyradical or like inferior gluteal nerve, or it can be a lumbosacral plexus, lower lumbosacral plexus. And these symptoms were gradually followed like over 3 years by right dorsum of the pain and right lower limb weakness, which has a progression similar to the left lower limb. And this was not associated with any of the trunk weakness or upper limb weakness or any other associated systemic complaints. So coming to the structures involved, after think in terms of either a left common peroneal nerve or L5 root, for a cotton wool sensation in under surface of left foot, I would think in terms of tibial nerve or S1 root. For a pain in right dorsum of the foot, I would think in terms of right common peroneal nerve or L5 root. For the motor complaints, for the initial symptoms, that is difficulty in lifting toes from the ground and clearing the foot from the ground, it indicates there is two extensors of foot dorsiflexion weakness. I would like to localize in terms of common peroneal nerve or L5, which was followed by difficulty in gripping chappal, and aware slippage of chappal indicates it is predominantly a motor symptom and indicates that it is the intrinsic muscles of toe and toe flexors. So I would like to think in terms of tibial nerve or S1 root in left side. And gradually there was difficulty in getting up from squatting position, which indicates a proximal muscle, probably a gluteus maximus muscle, which I would like to localize as L5S1 or inferior gluteal nerve. Now, thinning of gluteal, thigh and leg muscle, I would like to think in terms of L2S1 roots, lumbosacral plexus and or multiple nerve. And difficulty in using right lower limb with thinning of right thigh muscle, again I would like to think in terms of L2S1 root, lumbosacral plexus, multiple nerve.
Do you want to localize only in the lumbosacral plexus and peripheral nerve, or some other discussion do you want?
Sir, from this, predominantly, I would like to localize as lumbosacral plexus, L2S1 roots and nerve. Still, the possibility of anterior horn cell involvement, focal anterior horn cell involvement of lumbosacral segment, as well as cauda equina has to be. So, possible. I would. This is my summary for the possible structures involved, sir.
What are the structures? Peripheral nerve, lumbosacral plexus, and cauda equina.
Yes, multiple motor radical and cauda equina, sir.
Think of only an element lesion.
Yes, sir. It's a pure element lesion. Since the patient is complaining of flailness, there is associated wasting as well as twitching of the thigh muscles.
So, what is the possible pathology? It looks
possible,
multifocal, isn't it? What is the
yes,
possible pathology you are thinking?
Sir, in terms of for lumbosacral plexopathy, I would like to consider a neoplastic or a paraneoplastic disorder or a vasculitic disorder or idiopathic lumbosacral plexopathy. For multiple peripheral nerve involvement, I would like to consider mononeuritis multiplex, which can again be due to either a paraneoplastic or a vasculitis. For a multiple motor radical, I would like to consider paraproteinemia or lymphomas. And for cauda equina, I would like to consider inflammatory, neoplastic, vascular, and infectious causes.
But bladder and bowel is not at all involved.
Yes, sir. Yes, sir.
Then you can consider cauda equina.
No, sir. The cauda equina is very unlikely, but still, as a final
Then why
DD,
are
I
you
would like
bringing
to.
it?
Sir,
Then why are you bringing it in?
sir, there is element type of weakness, and there is a pain, asymmetry, some sensory complaints, and weakness. So I have just kept it as a last possibility, sir.
So can you give one diagnosis for this patient?
Sorry, sir.
Can you give one diagnosis?
Sir, one diagnosis I would think of lumbosacral plexopathy, sir.
It's an anatomical diagnosis. What is the pathological diagnosis you think of?
Sir, pathological, it considering the age, either a neoplastic, paraneoplastic, or vasculitis, sir.
Vasculitis at this age. What is her age?
So she's 56, sir.
56. So you think
Arunan,
of
Shraddha,
Yes, sir.
Arunan, can I
yes, sir,
interrupt?
yes, sir. It is yours, sir. Yours.
No, it's not mine, please. No, it's not mine at all. I'll only join in
Sir, you
questioning, that's all. Shraddha,
Yes, sir.
is it an unilateral problem or a bilateral problem?
Sir, it's a bilateral problem with a persistent asymmetry, sir.
Okay, so it is an asymmetric problem, but it's a bilateral problem.
Yes, sir.
Is it distal, proximal, or proximal and distal and proximal? What is it?
Sir, it started as distal, gradually progressed over 3 years to the proximal.
No, at present, after your history, is it distal and proximal?
Sir,
Or
both, sir. Distal
which
as
is
well as
more?
proximal.
Which is more?
Distal, sir.
Huh?
Distal is more, so weakness distal is more.
Okay. Is it motor or sensory or sensory motor? What is it like?
Sir, except it's sensory motor, sir, because there is a pain in dorsum of the foot and cotton wool sensation, sir.
And which is the predominant problem here? Motor or sensory?
Motor, sir.
So it's a motor.
Yes, sir.
So it's an asymmetric, distal predominant motor problem. Am I right?
Yes, sir. Yes, sir.
Involving the lower limbs.
Yes, sir.
Okay.
Progressive.
So, pardon? Banu madam, yes, madam,
Progressive.
please.
Progressive, I said. Sir.
Progressive, of course. Yeah.
Slowly progressive.
Progressive.
Slowly progressive.
Yes. Yes. Now, I am trying to reduce the discussion or structures that you are trying to incriminate. So,
Yes.
with this sort of a presentation, here you are listed, is lumbosacral plexopathy likely? We are talking of which is most likely, more likely. It's a bilateral, of course, yes, but asymmetric, yes, but bilateral.
Yes, sir.
So how often do you get straight away to say lumbosacral plexopathies?
Sir,
Or would you consider something else ahead of plexopathy?
so lumbosacral
Shraddha, this is only like in an examination, I'm questioning you, that's
yes,
all.
sir. Yes, I get it, sir. So lumbosacral
Yes.
plexopathy, usually a non-structural cause can present.
No, I know that you know about it. My question is that the first anatomical site of the problem which you would say?
Yes, sir, because it
You
was
listed
followed-
that as number one.
Yes, sir, because there is a pain which is followed by weakness and wasting, sir. So I thought
Pain, weak. Oh, 1 minute. Just
Yes,
hold
sir.
on.
Yes, sir.
Pain, weakness, wasting. What
Yes.
does it suggest? Does it say it is a plexopathy? What does it suggest? What involvement, what structure is involved to produce pain, wasting, and weakness?
So multiple radicals in the plexus, sir.
All that it says, it's neurogenic.
Yes, yes,
All that it says is it's neurogenic,
yes,
correct?
yes,
So it's a neurogenic problem which can be anywhere.
yes,
It's not necessarily it has to be in the plexus.
yes, yes.
Okay. You started off saying you identify the nerves which were involved. You started off identifying the nerves. Am I right?
Yes, sir.
So based on that identification of nerves, what do you think is this problem? What would be the first structure which you would consider?
Sir, initially it started, I told in terms of like.
No, forget all that. You identify, I am leading you on. You identified the nerves which were involved. So, is it a few nerves, single nerve, multiple nerves?
Multiple
what is
nerves.
Multiple nerves, sir. Multiple nerves.
it? So when you have a when you have a multiple nerve involvement, what would you term it?
So mononeuritis multiplex.
Multiplex. Yes.
Okay, agreed. One possibility is multiple single nerves selectively involved. Okay.
Yes, sir.
But here, even though it is asymmetric, the presentation is like the same kind of nerves are involved on both sides. Am I right?
Yes, sir.
Okay.
There is no
So-
non-contiguity.
So apart from mononeuritis multiplex, what other multiple nerve involvement condition you will consider?
Sir, asymmetric polyneuropathy.
Exactly.
Yes.
So it's a polyneuropathy. It's a polyneuropathy. Polyneuropathy, it may be a polyneuropathy per se, which is asymmetric in presentation,
Yes.
or it may be a mononeuritis multiplex. The difference being in mononeuritis multiplex, it's a selective nerve involvement. On both sides, usually it's not the same presentation, same nerves being involved, correct?
Yes. Yes, sir.
So it's more likely to be a polyneuropathy. If not a polyneuropathy, what else could it be?
Sir, it can be a lumbosacral plexopathy or polyradiculopathy.
Yeah, polyradiculopathy. Oh, see, you've been here for 2 years now in neurology.
Yes, sir.
When you have this sort of a presentation, would you first consider polyneuropathy, polyradiculopathy, or a plexopathy? How often have you seen bilateral plexopathies?
Yes. Not very often.
So why do you bring it on first?
Okay.
Your first consideration should be a polyneuropathy. Of
Okay.
course, what sort of polyneuropathy you will analyze later, depending, because it is asymmetric and how it came on, distal more than proximal. So between polyneuropathy and polyradiculopathy, which would you like? Which should you think it is likely?
Polyneuropathy, sir.
Why?
Because first of all, the pain, it is aching type of pain.
No. Forget that. Forget that.
It
Between
is distal to proximal.
can't it happen? 1 minute. Can't the pain happen with the radiculopathy?
Sir, it can happen, sir.
Then why do you say pain is the reason I consider neuropathy?
No, sir.
So what is the reason you consider neuropathy or radiculopathy?
Sir, I would
How will you
consider,
differentiate?
yes, sir, I would consider neuropathy based on a sensory and motor component. So sensory component being the pain, which is aching type of pain. Which is
Wait a
not
minute.
Wait.
We already said it's a predominantly motor. You only said it's a predominantly motor,
Yes, sir.
right?
Yes, sir.
So that doesn't matter. Can't
Okay.
you have sensory motor involvement in radiculopathy?
We can have, sir. Motor,
Then-
because there is a predominant distal weakness and it is progressing from distal to proximal, sir. And it is persistent to be asymmetric.
That doesn't matter. So because of that presentation, what do you say?
It's a polyneuropathy, sir.
Yeah, that is the differentiating point between polyneuropathy and polyradiculopathy.
Okay, sir.
That it is more distal than proximal is what differentiates it as a neuropathy rather than a radiculopathy,
Yes, sir.
right?
Yes,
So that should be the point which you should mention.
yes.
Not whether it is pain, not whether it's sensory, or not whether it's motor. The point to differentiate between a nerve and a radical is, in a radicular involvement, you will have proximal involvement, which is at least as equal or more than the distal involvement.
Yes, sir.
Here you already said it's a distal involvement, which is more.
Yes.
So between the two, you will consider polyneuropathy first.
Yes.
So this polyneuropathy might be a polyneuropathy per se of whatever other conditions you might think of, or mononeuritis multiplex, which probably doesn't look likely because it's not selective nerve involvement, neither of the limbs, though it is asymmetric.
Yes.
It looks as though the same nerves are involved on both sides.
Yes, sir.
Okay,
Yes.
that would be the discussion at this point of time based on the history. Now you can add on whatever else you want. You
Can I
also
just-
brought in. Yes, madam. Go ahead.
No, you finished, sir.
I finished.
Okay. Dr. Shraddha, you
Yes,
said
ma'am.
pattern of weakness. Will that help you to differentiate between a radiculopathy and a neuropathy? Because you were telling it's all this common peroneal nerve, that common peroneal nerve. So would
Yes.
that pattern of helplessness be, the pattern of weakness be of help to you in your analysis?
Ma'am, since it
The
is
way you are presenting was more of a polyneuropathy presentation.
yes, ma'am.
So,
Ma'am, like
Hmm.
during the course of the illness, the progression and like progression of muscle weakness is going in terms of a nerve pattern, ma'am.
that is what exactly I'm telling. So you presented everything like a nerve weakness. The
Yes,
muscle
ma'am.
weakness is fitting into a particular nerve distribution.
Yes, ma'am.
So that is why I'm thinking, why not it be a polyneuropathy?
Polyneuropathy,
I'm just
yes.
reiterating Dr. Viansa's opinion.
Okay, ma'am. Yes, ma'am.
Thank you.
Thank you.
Why upper limbs are absolutely normal?
Sir,
What do you think, which polyradicular neuropathy or polyneuropathy involves only the lower limbs without involving the upper limbs?
sir, like history-wise, currently it's only
It's
the
a
local.
systemic, whatever systemic illness you can think of, without involving the upper limbs, only the lower limbs. That too specifically localized, isn't it?
Yes, sir.
What else we can think of?
So paraproteinemias can present like lower limb involvement only, sir, initially.
Any history of
No.
tumor operated, any history of
Shraddha, the
chemotherapy?
question,
No, sir. No, sir.
Shraddha, the question is, the
Yes, sir.
question which Professor Maikandan is asking is why, when it's only a lower limb nerves which are involved, why is it the upper limb nerves are spared? So what sort of a polyneuropathy or a polyradiculopathy is this, wherein only the lower limbs nerves are involved? That is his question. So you give an answer to that.
Hello.
So if
Yes.
you think there are certain types of polyneuropathies or polyradiculopathies which can start off with the lower limbs, you will have to mention that. Or you will have to mention certain conditions which can involve the same structures, the roots or the nerves going to the lower limbs. So what are all those problems?
So diabetes can present like lower limb onset polyneuropathy. Then inflammatory causes can present, sir. Vasculitis.
What is the duration of the illness?
3 years, sir.
3 years upper limbs have escaped.
Shraddha,
Yes, sir.
Shraddha,
Yes, sir.
history-wise there is a lower limb involvement.
Yes, sir.
Is there any upper limb involvement? History-wise there is no upper limb involvement.
So history-wise, there is no upper, at current point of time, no upper limb involvement. So history-wise.
See, you
Something
also
on
mentioned,
examination.
Shraddha, you also mentioned another area. Why are you not discussing that? To the answer the question which Professor Maikandan asked. You said you talked about a cauda equina.
Yes.
So could this be a cauda equina lesion?
Sir, I would still consider as a possibility, considering the onset of pain, persistent asymmetry, and the motor symptoms. However, odd point is no bladder involvement, sir.
That is okay, ma.
Yes,
We are not pinning down to one
yes,
side.
sir. Still,
To
the
answer the
cauda
question,
Yes.
answer the question which Professor Maikandan asked,
Yes.
when you have only lower limb involvement, polyneuropathy or a polyradiculopathy like presentation involving only the lower limbs on
Yes.
both sides, what else will you consider? He also posed a question of a tumor.
Yes.
So what else you would consider? So
Sir,
this is where you will have to bring in a cauda equina lesion. It's
Okay.
asymmetric,
yes, sir.
multiple roots or multiple nerves, whatever, multiple roots here, if it is cauda equina.
Yes, sir.
And so then you will discuss why it's not that, we'll discuss later.
Yes.
Because the bladder, you don't need to have bladder involvement
Yes,
always,
sir. Yes.
depending on which roots are involved.
Yes, sir.
Okay. So to answer that question, this should be your answer. What else you will think of? It could be a cauda equina lesion. You discussed it earlier, but when your question is asked, you are not bringing that point in.
Yes.
Okay. Arun sir, it's back to you.
Sir, yes, sir. So shall we move on to the examination, sir?
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
So what was your final thinking, Shraddha?
So first
With
possibility,
history, we need to have a diagnosis, isn't it?
yes. The first possibility is a polyneuropathy. which can be either a paraneoplastic or a vasculitis. The second possibility is polyradiculopathy and then lumbosacral plexopathy, sir.
Why straight away go for a paraneoplastic and vasculitic? See, you have a polyneuropathy.
Yes.
It's asymmetric. So what is the commonest polyneuropathy, which is a progressive polyneuropathy involving multiple nerves? Of course, it is asymmetric, which involves distal and proximal. What is the commonest polyneuropathy which you have seen like that? Progressive over 3 years, picking up few nerves here, few nerves there, which has gone on to extended to involve the proximal also. What is the commonest polyneuropathy which you come across
Diabetes.
before going for paraneoplastic and vasculitic?
Diabetes, sir.
Diabetic, does it
But
present
here there is
as
no past history.
okay. Yeah.
And-
Diabetic neuropathy, well, it's a sort of the motor involvement is much more, not that you won't expect it, but such a motor involvement usually happens with an acute presentation. What is the thing? What is the commonest polyneuropathy? I'm putting my words into it.
Yes.
What is that condition called as Amma? Okay, no, I'll simplify it.
Chronic
It's a chronic
condition.
polyneuropathy. It's a chronic it's a progressive problem. It's going on for more than 3 years. Multiple nerves or multiple radicals are involved. So it's a chronic polyneuropathy. So what are the conditions you would consider in a chronic polyneuropathy?
So CID.
If it is, yeah, you were telling something?
CIDP.
Yeah, ma, why are you
Yeah.
hesitating so much, Amma?
CIDP.
Why are you hesitating? When you are talking of lumbosacral plexopathies, neoplastic, paraneoplastic vasculitis, what is the more common chronic polyneuropathy?
CIDP.
So that should be there, no? You
Yes.
have not mentioned it in your differential at all.
Yes, sir.
It may be CIDP or it might be CIAP, whatever it is. So it may be inflammatory, it may be non-inflammatory also. It's a chronic polyneuropathy.
It can be even paraneoplastic, sir.
Yes.
It can be, sir. But
Yeah.
I'm asking which is more common, that's all. So see, you discuss the common things and then go on to other possibilities.
Yes, sir.
So
Okay,
radicular neuropathy, possibly a CIDP variant. That is the thing that is in your mind now, isn't it?
Yes, sir.
Somebody has posted in the chat box also.
HIV.
Somebody has
is
asked
it
the question,
HIV?
CIDP variant.
Yes, sir. Somebody else posted, and another person asked whether it can be due to HIV related.
Okay. That will come to the etiology or pathology will come to later. Now
Yeah,
at the
yes,
present time, we are still trying to localize in the anatomical structure involved and how she will approach it. That's all. You have not mentioned it anywhere, Amma. That's why I'm asking you. Okay.
Another
Go
person
ahead.
has asked for something, sir. Some pain in the dorsum of the foot. You are relating
sir.
it to what? Whether it is due to musculoskeletal pain or it is due to nerve.
She
as
has
you said.
already said it's a nerve pain. She has
Neuropathic
said
pain.
it's a nerve pain.
Somebody has given a question whether it could be like that. So,
Sir, I
okay,
will-
you proceed with the examination.
Yes.
I am reading from the chat box, sir.
Yeah. See, somebody has asked why not human lower dorsal cord? There are no human features. That's why it's not considered as a upper motor neuron problem or a lower dorsal cord problem. Okay, proceed, ma.
On examination, she is moderately built and nourished with no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. The body mass index is 28 kg per meter square. There is no skin pigmentation, thyroid enlargement, or a breast mass. No neurocutaneous markers. No skin ulcers or skin changes. No nail changes. No cheilitis or angular stomatitis, and no peripheral nerve thickening. Pulse rate is 92 beats per minute, regular, with all the peripheral pulses well felt. Blood pressure is 130/80 mm of Hg in supine position. Respiratory rate is 12 and saturation is 100. Coming to higher mental function examination, it was normal with a MMSE of 29. Cranial nerve examination, first cranial nerve was normal. Second cranial nerve, visual acuity, color vision, field of vision, fundus examination was normal. The 346 cranial nerve, extraocular movements were full. There was no ptosis. Pupil was bilateral equal and symmetrically reactive to light. And trigeminal nerve examination, motor and sensory examination was normal. Facial nerve examination was normal with normal eye closure with no nasolabial fold obliteration or facial deviation. Vestibular cochlear nerve examination, Renes air conduction was better than bone conduction with Weber centralized. For 9th and 10th, cranial nerve examination was normal with uvula central palatine movement symmetrical and gag reflex intact. Neck flexion, extension, head turning and shrugging was normal. And hypoglossal nerve, tone, bulk and power of the tongue was normal. Spinomotor examination. On inspection, bulk in upper limb, there was a hypothenar wasting in left hand and right hand, there was no wasting. Forearm and arm muscles were normal. In lower limb, in the left lower limb, there was a gluteus muscle wasting, thigh muscle wasting, including anterior, medial and posterior compartment of the thigh, and calf muscle wasting, both gastrocnemius and soleus wasting, with the dorsal growing of foot and clawing of toes. In the right lower limb, the right gluteal muscle and thigh anterior and posterior muscle wasting was present with the medial thigh sparing, with the dorsal growing of foot and clawing of toes. Tone examination. In upper limb, proximal was normal, distal hypotonia was present, and in lower limb, hypotonia was present, left more than right and distal more than proximal. There was no fasciculation in lower limb, paraspinal muscles or upper limb. Coming to the power examination, in the upper limb, the shoulder, elbow and wrist movements all were 5/5 in both the upper limbs. In intrinsic hand muscle examination, hypothenar muscle and third and fourth intraossei were weak in both left as well as right hand, and thenar muscles were normal. In lower limb examination, in the left lower limb, the hip flexion was 4-/5, hip extension was 3/5, adduction and abduction was 4-/5. In right hip, the flexion was 4+/5 with adduction abduction 4+/5 and extension 4-/5. In the knee examination, knee flexion and extension both were 4-/5 in left side and 4+/5 in right leg. In ankle examination, the dorsiflexion in left side was 2/5, plantar flexion was 3/5, inversion was 2/5 and eversion was 2/5 with a toe grip weak. And in right side, dorsiflexion was 3/5, plantar flexion was 4-/5 with inversion and eversion of 3/5 with weak toe grip. The superficial reflex, the corneal reflex was intact, abdominal reflex was absent in all the 4 quadrants. The plantar reflex was bilateral flexor and anal wing reflex was intact. Deep tendon reflexes, jaw jerk was normally elicitable. In upper limb, bicep, triceps and supinator was normal, 2+. In lower limb, knee was diminished with 1+. Ankle jerk was absent and hamstring reflexes were absent. Sensory examination, touch, pain and temperature was intact in all the 4 limbs. Position and vibration was intact in all the 4 limbs, and rhombox sign was negative. The cerebellar examination was normal and the spine examination showed scoliosis with convexity to the right. The systemic examination was normal with a normal cardiovascular, respiratory, and perabdomen examination was soft, non-tender with no organomegaly. So after examination, the structures involved was pure motor weakness of all 4 limbs.
What's the gait? How about the gait?
Sorry, sir?
What was the gait? Gait.
So gait, she could only walk with a support, sir. It was a high stepping type of gait, sir.
Right, thank you.
So after examination, structures involved were, it was a pure motor weakness of all 4 limbs, left lower limb more than right lower limb, distal more than proximal, with a hand muscle wasting and weakness in hypothenar muscles, with a normal upper limb proximal and normal sensory, higher mental function, cranial nerve examination and cerebellar examination.
So what will you think now?
Sir,
Continue your discussion based wherever you left off with the history. Now continue and tell us your possibility.
Sir, after like examination, since there is a pure motor weakness and asymmetry as well as significant wasting, I would like to consider in terms of one possibility of focal anterior hornsel disease in lumbosacral segment, and also possibility of polyradiculopathy, motor polyradiculopathy of L2S1 segment, or a lumbosacral plexus, or multiple peripheral nerve as a last possibility.
Shraddha, after examination, what is the added point in your examination? Then you discuss.
Sir, added point was like in lower limb, there was a wasting in thigh in all the compartments, leg and foot, and right anterior and posterior compartment only, with no
Shraddha,
articulation.
Shraddha,
And
1 minute,
upper limb, there was upper limb involvement, sir.
That is a more important point in your discussion. In the
Yes, sir.
clinical examination, all the history are confined to the lower limb. After the examination, there are the findings in the upper limb. With the
Yes.
upper limb, then you discuss where is the lesion, what are the lesions, where can you localize the lesion? Is in the peripheral nerve or radical or flexopathy, multiple.
Yes. So after examination, one possibility I would like to get into the picture, considering the motor weakness and the wasting, anterior hornsel disease, sir, as an additional possibility.
Possibility, why there is in the upper limb, why there is a disparity, localized in the upper limb wasting and weakness?
Sir, it is currently only in the hypothenar muscle and the intraossei. So more of a nerve pattern, ulnar nerve pattern, sir.
Then why are you bringing anterior hornsel in the upper limb and
Yes.
discuss?
Yes. But
Sir, can everything fit into an anterior hornsel pattern, upper limb as well as lower limb?
no, sir.
Or can everything fit into a neuropathy pattern, upper limb and lower limb? This
Ma'am.
obviously cannot fit into a plexus pattern when you consider the upper limb also.
Yes, ma'am. Like the only one thing is still the upper limb thinning was found incidentally, and she has no complaints. So we have to see for a progression of the disease to put whether it is anterior hornsel. But currently she has in upper limb in a nerve pattern, ma'am.
So
Is
you
there any neuropathy
you're-
which can present like this? Shraddha,
Yes, sir.
is there any neuropathy which can present like this?
Sir,
Do you know of any neuropathy?
Sir, mononeuritis multiplex itself can present like this. In lower limb, it would have become a confluent and presented as a current on our presentation. She should have presented as polyneuropathy, and now upper limb ulnar nerve is involved as a part of mononeuritis multiplex.
Shraddha, why
No,
there
no,
is predominantly motor involved? That's why sorry.
Yeah, see,
Why there is predominant motor, sensory it is paired?
is mononeuritis multiplex? Is it a motor neuropathy or is it a sensory motor neuropathy?
Sir, it is predominantly sensory motor neuropathy, sir.
Then why do you say that here? You already said it's a pure motor problem.
Yes, sir.
And then why do you want to bring in that? So I was asking you, is there a neuropathy which can present with as a pure motor problem?
Multifocal motor neuropathy.
Yes,
adduction block.
you have not discussed that at all.
You have to discuss after examination. Since there is
That should be one of the top differential diagnosis, isn't it? With the findings which you have discussed.
And she also said about CIDP, whether this fits into a CIDP also.
CIDP, like
Variant.
unlikely, sir, because still there is a asymmetry, ma'am. Usually at this point, after 3 years, usually a symmetrical will be there and proximal will be more than distal. Here, there is a distal more than proximal and persistent asymmetry in whole of 3 years.
Can some of the variants of CIDP be having a picture like this?
Ma'am, MATSAM variant can present like this, but usually it will have a sensory component also. It won't be like pure motor. But
Okay.
one of the DD is MATSAM variant.
Okay.
So that also becomes your differential diagnosis. See,
Diagnosis.
you don't have many differential diagnoses with this presentation.
Yes.
Your top differential diagnosis would be either a multifocal motor neuropathy or a CADP variant, which can, I mean, you can consider mononeuritis multiplex as any one of these.
Yes.
But since it is usually it is sensory motor, here you have pure motor. The same objection which you raise for CADP holds true for mononeuritis multiplex also.
Multiplex. Yes.
Sir, can I come in, sir? 1 minute.
Please, Vijayan. Welcome.
No, sir. Just advice to the presenter. When you're presenting in the exam, and after the exam, ask the question, can it occur like this? Then you have to say, yes, madam.
Okay.
That
Sir.
is,
Yes.
that's all.
Yes, sir.
That's why madam was repeatedly asking like,
Yes, sir. Yes. Yes. Sir.
okay. She's
And
giving
you
a
should be
clue.
convinced also. You should be convinced also.
That's
No,
right.
Present like
madam,
that.
madam was giving you a
I
clue
may take
again.
her down the devil's path, Dr. Vijay.
Madam was repeatedly giving you a clue. So you should say,
Because-
yes, madam.
Yes,
Because
ma'am.
that was the thing she spoke last in the history as
Yes.
her diagnosis. So I was expecting her to start off with that here in the after the findings.
Yes, ma'am.
Okay, that's all. Just a piece of advice to the exam. Right.
Yes. Yes, sir.
So
Anand, can she proceed?
Uh,
Anand, do you want her to say anything further or to go ahead with the investigations?
I think he's not there. I think she can go ahead,
Arnand?
sir.
Okay.
Coming to the
Sorry, sir. He can go ahead,
No,
sir.
no.
She can go ahead.
Okay,
Ah.
right. Thank you.
coming to the investigations, the ECG, complete blood count, RFT, LFT, serum electrolytes were normal. Peripheral smear was normal. ESR was 30 and serum calcium level was 9.6. And MRI LS spine with whole spine screening was done, which showed a disc dehydration with diffuse disc pulse, noted in L2 to S1 levels with a mild transversing nerve root abutment. Nerve conduction study was normal, which showed bilateral lower limb motor nerve was not stimulatable. Lower limb sensory was normal, and motor and sensory in upper limb was normal, with a suggestion of bilateral lower limb motor axonopathy. Next, as a workup, MRI of lumbosacral plexus was done, which was normal, and a needle EMG was done, which showed a neurogenic pattern. Serum protein electrophoresis.
Shraddha, just hold on for a minute.
Yes,
Shraddha,
sir.
just hold on.
Yes.
Hold on.
Yes, sir.
Can you tell us what was the nerve conduction values? What do you mean by neurogenic pattern? You will have to expand it further. What do you mean by neurogenic pattern? What was the finding?
Sir, there was incomplete recruitment with the fibrillation potentials with positive sharp waves, sir.
No fasciculations.
So there was fasciculation, sir. Like fibrillations were fasciculations were there, sir, in needle EMG.
No, you have to be definite. You said anterior horn cell you brought into the differential diagnosis.
Yes.
So to differentiate, what differentiates an anterior horn cell from a nerve problem or a root problem
So
in the EMG?
yes, sir, fasciculation, sir.
So you should be sure fibrillation need not equate with fasciculations. Positive sharp waves, of course, can happen with nerve problem also.
Yes, sir.
So you'll have to specifically say what was the finding in the EMG.
Yes. In needle EMG, it showed a positive sharp waves with fibrillation potentials with the incomplete recruitment pattern, sir.
Okay, right. Now again, see you said normal conduction in upper limbs, normal
Yes, sir.
conduction, including
Yes.
the ulnar nerve,
Yes, sir.
including the ulnar nerve.
Yes, sir. Yes, sir.
Can you give us the values?
Sir,
You have come to again, see, okay. What neuropathies are we considering here?
sorry, sir.
What was your primary differential diagnosis amongst the neuropathies at the end of the examination? What did we discuss?
Sir, mononeuritis multiplex, sir, and multifocal motor neuropathy with conduction block.
So should you not expand and say whether there was a conduction block, no conduction
Yes.
block, what was it in the upper limbs? You just say
Yes.
pass on saying it's normal. What was the district latency like? What were the F waves like?
Sir, in upper limb, like motor latency was normal, action potentials were normal, F wave was normal, and there was no conduction block, sir.
No, all that has to be mentioned.
Okay.
See,
Yes,
primarily
sir.
we are discussing a neuropathy. We are discussing a neuropathy wherein we have discussed both demyelinating neuropathy and a multifocal motor motor neuropathy. So the essence
Yes,
is
sir.
only the nerve conduction studies.
Yes, sir.
Without giving more details, it becomes difficult.
Yes, sir. Sorry.
You already said it's a motor axonopathy. What made you say it's a motor axonopathy?
Sir, motor nerves was not stimulatable, sir. So possible motor axonopathy. Whereas
But what was
sensory
it
normal.
did the upper limbs give you any clue for an axonopathy? You said the upper limbs, everything was normal, including ulnar nerves were normal.
Yes, sir. Everything was normal.
There was no reduction in the amplitude of the CMAP
No, sir. No, sir.
between the right and the left ulnar.
No, sir. No, sir.
Okay.
You have the list of the conduction findings that may be.
Now, what was the?
Yeah.
You
Sorry, ma'am?
say it is, what was it was a motor axonopathy. It was not demyelination at all.
Sir,
Your nerve conduction velocity.
demyelination-
Your
Sir,
nerve conduction.
Sir, in
Yes,
our nerve condition, when she presented to us, both the lower limb motor nerves were not stimulatable at all, sir. So, we cannot, usually severe demyelination may present as a secondary axonopathy, or it can be a primarily axonopathy.
See, even in GBS, sometimes the
Yes, yes.
nerves are not stimulatable.
Yes, ma'am.
So that is also there. So we cannot always take a not stimulatable is equal to axonopathy. Of course, it has to be interpreted in the clinical setting.
Yes, ma'am.
Okay, my point was that you should have given more details regarding the conduction, which is the most important thing as far as this case is concerned. Okay.
Even now, she can just put up that slide, sir. If she has got it, she can just add on to it.
Madam, she may
I
not
don't
be
think she
having
has it.
maybe-
Okay,
I don't think she has it.
okay.
Phone.
Okay, ma, proceed.
MRI lumbosacral plexus was normal. Needle EMG showed neurogenic pattern. Serum protein electrophoresis was
Somebody had raised a question with regards to that EMG that was in the chat box.
When
What was it?
fasciculation or fibrillations are present, you need not expect conduction block. He has mentioned like that.
No.
It's a
And NCS has no conduction block. Discuss. No. What he said, EMGs are
and
valuable.
NCS.
Fasciculation and fibrillation are present, and the conduction study does not show a conduction block. Then what is it? Is the question he has asked. I think that's what he is asking.
Yes, sir. He thinks conduction block should have been there.
No, if the conduction block was there, it will point to a multifocal motor neuropathy. So that is excluded because there is no conduction block. So without multifocal motor neuropathy, what is that condition which gives fasciculations and fibrillations? That is the question. If I am right, that's what I think. I don't know. Ramki has asked the question.
You can unmute and talk, sir. Ramki, you please unmute and talk. Sir,
Okay.
proceed, sir. He won't talk.
Okay. Go ahead.
Serum protein electrophoresis.
But Shraddha, you should answer the question. No? This can be asked in the exam. Examiner can ask this question. So what would you say then? There's no conduction block. So it's not a multifocal motor neuropathy, right? But yet fasciculation, you didn't mention fasciculation, but yes, fasciculation and fibrillation are there. So what are the possibilities? If you know, yes, or otherwise you go ahead.
The right one.
Okay, proceed. So what, I don't know what he is leading to. Of course, you will consider an anterior disease, but the clinical picture does not fit in with an anterior disease. But fasciculations, again, that's why it's important how much of fasciculations you see, how much fibrillation. Positive sharp pace goes with any nerve involvement. It doesn't localize further. Again, fibrillations also, to some extent, it goes with a nerve, acute nerve injury can give rise to fibrillations.
Yes.
Only thing, fasciculations we don't see with an acute nerve injury, but sometimes you see with radiculopathies. But most often we associate it with anterior onset disease. Here, the clinical picture is not of an anterior onset disease. So maybe it points to a radiculopathy if fasciculations are there, but you said you did not find fasciculations. I think that was your conclusion. You said only positive sharp pace and fibrillations,
Yes,
which
sir.
can happen with any neuropathy for that matter.
Yes.
Okay, proceed.
Serum protein electrophoresis was done, which showed in a M spike in IgG lambda, that is value of 0.8, and immunoglobulin profile was done, which showed increased IgG, the normal value being 650 to 1600. In our patient, it was 1892, and IgM and IgA were normal. Paraneoplastic panel, which included ANA 1, 2, 3, and anti-PCA 1, 2, and anti-CRMP5 was done, which was negative. And vasculitic profile, which included ANA and ANCA, it was negative. Bone marrow.
Did you look for myelin? Shraddha, did you look for myelin-associated glycoprotein, MAG antibodies?
Yes, sir. In our case, it was not done, sir. But for it usually it is positive in DATS variants.
No, no. I'm asking in your patient.
Sir, usually anti-MAG, it is not done, sir. In our patient, it is not done, sir.
Okay.
Bone marrow aspirate showed reactive marrow with 5% of plasma cells. The PET scan was done, which showed a metabolic.
That is considered normal or abnormal?
Sir, it can be considered as a monoclonal gammopathy of undetermined significance, sir, currently.
No, with 5% plasma cells.
Yes, sir.
No, I'm asking about the bone marrow result.
Sir, it can be either a normal or it can possibility of monoclonal gammopathy of undetermined significance. But considering the like M spike, we should take it as MGUS.
No, ma, I'm asking about the bone marrow aspiration, result of the bone marrow aspirate.
Sir, it was done with correlation, sir. Report was given as MGUS, sir.
No, madam. Sir is asking only about bone marrow. Just if you see the bone marrow, will you say it is normal?
I think what she is trying to tell is with this 5%, that's what I understood. 5% can be normal, but here that there is an M spike,
Yes.
this is supposed to be abnormal. Am I right, Shraddha?
Yes, ma'am. Yes, ma'am.
Okay.
No, that is based on the electrophoresis, madam. I am asking.
Yes,
Shraddha, I'm asking only. I do not know. That's why I'm asking. Bone
No,
marrow
that's what she
aspirate,
said.
5% plasma cell.
This can be
Is
normal
that
or
5%
abnormal,
plasma
she
cell
said.
normal or abnormal? Forget about electrophoretic pattern.
Sir, when there is no electrophoresis, this can be normal, sir.
That's all I wanted to know. Right, fine.
PET scan showed metabolically active bowel wall thickening noted involving cecum, suspicious for extramedullary involvement, and biopsy was suggested. However, there was no metabolically active disease noted elsewhere, or no metabolically active lytic skeleton lesions were noted. This was mainly to rule out because the bone marrow aspirate and serum protein electrophoresis had given a few findings of M protein and plasma cells. Colonoscopy was done since there was cecal thickening, which was normal. Currently, the plan is to do a diagnostic laparoscopy, which is awaited to rule out any structural cause, since PET scan had shown cecal extramedullary thickening. Sir.
I think
somebody has asked whether anti-GM1 has been done.
No,
I'm
sir.
sorry to intervene. I personally feel it will be hazardous to go for laparoscopy. Maybe it's my personal opinion. This type of report you always get it.
Yes, sir.
Yes. So I don't think with this report,
yes,
you can suspect some carcinoma of malignancy of the small intestine or the cecum or
yes,
large intestine.
Yes.
I don't think you have to go for laparoscopy.
Yes.
Shraddha,
Yes, sir.
at present, what you have found is a paraproteinemia. Am I right?
Yes, sir.
It's a paraproteinemia.
Yes, sir.
Yes or no?
Yes, sir. Yes, sir.
Okay. And you don't have a cause for the paraproteinemia.
Yes, sir.
That's why I was asking about the bone marrow. Bone marrow is
Sir.
considered normal.
I'll just tell you one thing, sir. Sorry for butting in. I was just looking up. It says the plasma cells make up to 2 to 3% of the cells in the bone marrow in normal people. If it is more than 10%, that is favoring multiple myeloma.
Myeloma.
In between range, they have not said anything.
Yes.
This 3
Gray
to 10.
zone.
Gray
It's
zone.
a gray zone.
Yeah, gray
Gray.
zone.
So it
So,
can be considered
now-
as a monoclonal gammopathy of undetermined significance based on that plasma cell value.
That is also a paraproteinemia, Dhanama.
Yes, sir.
Sorry, MG usually presents like that, sir. It will gradually go on to develop multiple myeloma. That is possible.
Yeah, maybe later. Yes, that's different. Yeah, maybe it can turn out to be myeloma. But at present, what about Bence-Jones protein in the urine?
So urine Bence-Jones protein was not done, sir.
Simple test, Amma.
Yes. Sir.
Okay. Somebody had asked a question whether what anti-GM1 antibody was, whether it was done.
Sir, it was not done.
In the chat box, there's a question.
No, sir, it was not done, sir. And usually anti-GM1 like antibody, we will do mainly when we are suspecting MM and CB or acute. This is chronic, so the one better.
Sorry, 1 minute. When would you, what was your answer? When will you do it?
Sir, anti-GM1 will be done when we are suspecting a CIDP, sir.
Yeah, but you're here also you suspected.
Suspect.
Yes, sir.
No, the question who somebody had asked, I don't know who, I have not checked in the chat box. In multifocal motor neuropathy, you will find it. That is, I thought that was the reason why the question was asked.
It was not done, sir. Anti-GM1 and anti-MAG was not done, sir.
Yeah, fine.
Did you do CSF?
No, ma'am. Actually, the
that's
patient was not willing for CSF, ma'am.
That's another important
He went for
investigation
bone
to be
marrow. He
done.
was not willing for CSF. Very
No, ma'am.
surprising.
Yes.
Less painful procedure.
Yes.
Less simple. less
That is a
painful.
must here.
Yes, ma'am.
That's an investigation which is a must here,
Yes.
particularly with the differential diagnosis which we are discussing.
Yes.
Even if it's a paraproteinemia, or even if it's a CIDP, or even if it's a multifocal motor neuropathy, CIDP, I mean, CSF we need, no?
Yes, sir.
Okay,
Yes.
at least you should have mentioned CSF not done, patient not willing.
Yes.
Otherwise, we won't know whether you considered it or not. I'm talking of an exam.
Yes. Yes.
Okay. So proceed. So paraproteinemia, it's a, according to you, MGUS,
Yes, sir.
which is again a
because-
paraproteinemia. Okay.
Yes.
But what can I ask you? What is the presentation of the MGUS?
Sir, MGU is usually present as a 3 forms, sir. The most common form in DATS, like distal asymmetric sensory form, usually seen in IgM phenotype, and it can present as a CIDP.
No, I
usually-
want to answer to only one thing, one question mark.
Yes, sir.
MGUS, is it a motor neuropathy or is it a sensory
Sensory
neuropathy
motor
or is it a
neuropathy.
sensory motor neuropathy?
Sensory motor neuropathy, sir, commonly.
Which is predominant in MGUS?
Sensory motor, sir.
Amongst the sensory motor, which is predominant?
Sensory, sir. Sensory.
Yes. So all MGUS, sensory component is the predominant component.
Yes.
Your patient does not have sensory involvement.
Sensory. Yes.
I'm not saying it is not paraproteinemia, but I'm just pointing out to you that sensory component is an important feature. That is the presenting feature that is not here.
Yes.
Okay.
Only
So,
50% is the sensory component, sir, TSAN. And the CIDP can also occur in 28% of cases.
Yes, sir.
With,
Especially IgG.
of what, sir?
Sir,
MGUS.
Of
MGU.
what?
sir,
Arnand, of what?
MGUS, 15% will have neuropathic involvement, sir. There are 2 types of MGUS. With
Correct,
N
correct.
is with neuropathy, NN is without neuropathy. So 2 are there.
Correct, sir. But that amongst the neuropathy, the sensory neuropathy is the predominant one, I'm
Yes,
saying.
sir. 50%, 50%. 28% is CADP and 17% is DATS. So
Correct.
you can consider
Okay,
the
that's
CADP
okay.
also, sir.
Sorry, yes,
CADP,
yes,
CADP you can consider.
paraproteinemia, CIDP-like presentation can happen.
Yes.
So can
my point
can I
was
come in?
sensory component is an important feature of paraproteinemia. That's all. MGUS.
Yes.
So can I come in?
Please, sir.
Yes, sir. Yes, sir.
Only one point to add. If you have a doubt on the bone marrow, you have to do cytogenetic studies. Cytogenetic studies just look for CD38 to demonstrate clonality. That is one. And two,
Can you,
when
one
you call
second,
it,
Dr. Vijay, can you just repeat it?
you do cytogenetic studies, madam, to see look for CD38.
Okay.
Immunohistochemistry
Okay.
to look for CD38 to demonstrate clonality. When the number of plasma cells is so low, percentage is in between or it's in the gray zone, we'll do immunohistochemistry to look for CD38. Then you can demonstrate clonality to some extent. One.
Okay.
Two, when you call this, you'll have to call it monoclonal gammopathy of neurological significance. If at all, if that is negative, then we'll call it monoclonal gammopathy of neurological significance, not undetermined significance. Two
Sir,
and three, it
your
requires
voice is
treatment.
breaking. Vijay, your voice is breaking. Couldn't hear you properly.
Yes, I'm traveling.
Sir, pretty bad.
Not audible.
It's worsening, getting worsened.
Second thing he said was you call it as monoclonal gammopathy of neurological significance, not unspecified.
Yes.
Madam, it is unspecified with neuropathy.
MGUS can be associated with neuropathy. Yeah. So it's still MGUS only.
Yes.
With neuropathy.
Neuropathy.
In other words, it's a paraproteinemia, where you have either, you can have IgM, IgA, IgG, whatever, you can have that. Here you have IgG.
Can follow any pattern, sir. We cannot determine it will be like this one.
Yeah, that's right. That's what I'm also saying.
Yes, sir.
So it's a paraproteinemia. Broad term is paraproteinemic neuropathy.
Yes.
Which can present like a CIDP, which can even present like a mononeuritis multiplex.
MMN. Sir, Vijayan is trying to come in, I think. Vijayan?
Yes,
Yes,
sir.
yes, yes.
Yes, sir. That's
Yes,
what
sir.
we
Talk, sir. Talk, sir.
just to tell that, madam already told that you call it monoclonal gammopathy of neurological significance, and it needs treatment.
What treatment
Yeah.
was given, Shraddha?
Yes, sir.
We'll ask her, sir.
Vijayan, neurological MGUS is okay. You can qualify it further, stating that is with neuropathy. That's what Arun said. MGUS
Yes,
with
sir.
neuropathy.
Yes, sir. With
Yes,
neuropathy,
yes,
with
sir.
such severe
Yes.
neuropathy, it requires treatment. That's all.
But usually such severe neuropathy like what she has presented is not an accompaniment. Usually it's a sensory neuropathy.
Usually it's not an equipment. That's what I want to try to tell, sir.
Yes.
So we'll call
Yes,
it
that's all.
monoclonal gammopathy of neurological significance, and it requires treatment. That's all. That's what point I wanted to know.
So what treatment was given? Actually, we are running late by 10 minutes.
Okay.
We are running late by 10 minutes, sir.
Carry on, Arun. No interference.
Shraddha,
You carry on.
Shraddha, what was the treatment? Can you proceed?
What is
Sir,
regarding the treatment, sir? Arnan, sir.
Tell me, sir. What treatment was
Ravi
given,
Kumar,
sir?
not audible, Ravi Kumar.
Sir, planning for IVIG or rituximab for this patient, sir, but affordability and drug is not available.
For
I think,
IVIG, sir. Someone has asked for that also.
No, I think Rituxi will be preferable.
Yes, sir.
And we have Vijayan, the Rituxi man.
Yes, sir.
Rituxi is preferable here.
Yes, sir.
Yes, sir.
Rituximab will be preferable.
Directly attacked.
Any hematological inputs into the case? Any
No
consultation?
Madam, now
Hematology?
is here, madam. No,
I have done
hematology.
peripheral smear and all, sir. Madam.
No,
and
hematologist opinion. Ravi
Sir,
Kumar, hematologist opinion எதுவும் கேக்குறாங்க.
இல்ல சார் இங்கே ஹெமட்டாலஜி இல்லாம கேட்க முடியல சார் வெதர்
Okay.
ரிச்சி சார் பட் our plan is to give rituximab for this patient, sir.
Okay.
Yeah, yes.
Yeah, I think it can go ahead.
Very good, sir. Very good.
I think my CSF may be done before that. That may be my
The
suggestion.
patient is saying no means.
At least for
You can just-
completion's sake, it must be there. Ravi, documentation completion, it must be there.
Yes, sir. Yes, sir.
Can maybe
Sir,
talk
what
to the
about-
patient again about this, and patient may think agree second time.
Yes, madam. We are
What about nerve biopsy, madam?
Oh, yes, sir.
What for? Meghandan sir.
Yes, sir.
What for? We are fairly clear as to what we are dealing with.
I'm not clear. That's why I asked.
No, how will now biopsy add anything?
Give it.
No,
I-
biopsy is not going to tell us the etiology. It's only going to tell us whether axonal involvement,
Demyelination.
The vasculitic neuropathy and all those things. Paraproteinemic also they can definitely
Yeah,
suggest.
that's right. So
Whether
it's not
infiltration
going
is
to
there.
add much to our etiology.
Because
Sir,
the
it may show paraproteinemia. Show
paraproteinemic
Plasma cell
neuropathy is also not very much confirmed.
The patient not respondent to IV methylprednisolone given by in 3 institutes, sir.
Oh,
No significant response to steroid for this patient.
Oral steroid தானே சொன்னாங்க.
IV கொடுத்திருக்காங்க சார். IV ஒரு 2 இங்க TMCH
Once.
But usually paraproteinemia, you can't expect improvement.
Yes, sir. Yes, sir.
Plasmapheresis, sir.
Plasma paresis acute exacerbation we can give, sir, but it is a
Now
progressive,
it is not useful.
not useful, sir. Even IVIG also, that's why
Rituxi will be the best thing.
Rituximab may be best.
Ideal will be Rituxi.
Yes, sir.
It's not very costly also compared to IV.
That's why we are presenting the case how to plan for the treatment also, sir.
What is the proof that it is MGUS related, sir? There is no proof at all.
Yes,
There is
sir.
a lot of people, asymptomatic people have MGUS. There is no proof that the whole story is MGUS related.
When
And
there is
Chitrambalam, sir,
neuropathy, we can-
Yes, sir. Yes, sir. The
Ah,
neuropathy so far is presented for a long
Chitrambalam.
time. At the end, no etiology. I'm not very convinced about
Yeah.
any etiology.
Chitrambalam,
MGUS is very
correct,
common
correct,
among very many people, sir.
what you say is very true. இங்க என்னன்னா IgG is elevated,
Yes.
and
Yes,
apart from that, the plasma cells I was asking, it's in the gray zone. But then clinical picture, if you consider paraproteinemia, it fits in. Though, as I said, sensory should be a major component of it. Here, it's not a major component.
And what is
But
the
then
light
we do
time
not have
ratio?
it.
What is the kappa lambda ratio? So lambda kappa ratio, is it reversed? Kappa lambda ratio, is it reversed? And even if it is reversed, and even if you prove that the lambda chains are much more, and there is no proof that this MGUS is the cause. MGUS is such a common phenomenon after the age of 50 that you can't correlate it with the neuropathy. Many people, you take 100 asymptomatic people, and many of them will have MGUS. MGUS has no correlation. So then again, this peripheral neuropathy can be simply due to another treatable cause. Without a biopsy, I don't think coming to a conclusion MGUS will lead to trouble only. Especially treating MG, if you feel it is a paraproteinemia and monoclonal gammopathy, you'll have to treat you'll have to discuss with the hematologist and treat the monoclonal proliferation, not simply with rituximab or IVIG or steroids. And I don't think this patient has MGUS related neuropathy. There is no correlation between these two. That's an asymptomatic phenomenon occurring in many people. Nerve biopsy is a must for
Chitrambalam,
this
your
patient, I
point-
feel.
Chitrambalam, your points are well taken. Only
sir.
thing is, it is here, IgG is elevated. As
Yes,
she
sir.
said, it's probably an axonal neuropathy because
Yes,
the
sir.
lower limb nerves are not stimulatable. Of course,
Yes,
if
sir.
she had given some values regarding the upper limbs, it might have helped us. She has
Yes, sir.
not given, but she says the Fs are normal in the upper limbs. So probably it's an axonal. Axonal with IgG elevated. We have to consider that. It may not be certain because, as
Yes,
I
sir.
said,
And many
sensory
significant patients
is
have
not
peripheral
there.
neuropathy like this with a lot of
but the only thing,
disabilities.
Chitrambalam,
You
I have only one
you do
question to you.
a study of this, you will find that there is evidence for MGUS in many patients, and the correlation is sometimes
Yes,
very,
yes,
very
agreed,
difficult. Sir.
agreed.
Yes, sir.
This is the
Agreed.
nearest fit.
I know some of the neurologists themselves have MGUS and they have no problems. That's a different
sir.
matter. But
Yes, sir.
but the question is, You
Yes,
wanted a biopsy. You tell me
Yes, sir.
what
MGUS is
how
a
the
age-related
biopsy is
phenomenon.
going to
Only
be
if it
helpful.
degenerates into a multiple myeloma,
Sir,
it
can
is
I
trouble.
come in?
And
Can I
MGUS,
come in?
many patients does
Vijay
not
Nonga.
do any harm.
Can I come in only to answer
Yes, sir.
Chitrambalam's questions?
Yes, sir.
Only the only answer would be to do cytogenetic studies in the bone marrow, to immunohistochemistry to demonstrate monoclonality.
And before that,
now
light chain
biopsy,
ratio, kappa lambda
Yes, sir.
ratio.
That would have already
Kappa
been
lambda
seen.
also has to be done. Whether it
Dr.
is
Chitrambalam,
normal or
that,
abnormal has to be seen.
Dr. Chitrambalam, that is already
She had mentioned lambda. I don't know. I do not
That
know
is
the
already
ratio.
there in the
She had mentioned
No,
immunology.
lambda.
but the
Sir.
kappa lambda ratio is also important. There is only
Sir,
lambda
sir.
mentioned.
So that, yes, sir, she's mentioned that, but that would already have. But the only thing you have to do extra is to do a cytogenetic study of the bone marrow, immunohistochemistry, and yes, plus or minus bone marrow. Yes, I would strongly favor an biopsy also to look for paraproteinemia and nutrients.
Thank you, Vijayan sir, for your opinion. We will get an hematologist opinion, then we will proceed, sir.
Yes, sir.
For this case.
So everybody knows.
Sir, next case.
Sir, we'll
Next
go for
case,
the
sir.
next case, sir.
Yes, sir.
Chitrambalam,
Sir.
Thank
There is
you.
only
we'll go to the next case.
Thank you, Shraddha.
Thank you,
Thank
sir.
you. Thank you, Shraddha. Well done. Well done. Thank you very
Thank you,
much.
sir. Thank you.
No, must
Ravi
thank
Kumar, sir, you
Chitrambalam
can-
for bringing in many points for the discussion. Yes.
Yes, sir. Ravi sir, we'll go to the next case. Thank you, Shraddha.
Yes, sir. Dr.
Thank you,
Ravichandran.
Shraddha.
Thank you, sir. Thank you, sir.
Ravi sir,
Yes, sir. Dr. Ravichandran will
we'll
present
go
the
to
next.
the next.
Yes, sir. Yes, sir.
The other Ravi, junior Ravi, you come on.
Ravichandran.
So you share your.
Shraddha has to stop sharing.
Shraddha, stop sharing. Ravi, start sharing. I think Ravi is afraid after Shraddha has got these many questions.
Possible.
Imagine we used to get it once a week or twice a week.
No, we will not ask him any questions. We'll leave him to
Ravichandran.
present in full.
Ravichandran.
That was a very tough case to present, sir. No doubt. No doubt.
She did well.
Yes, sir.
Yeah, she did well. Actually, she did well. It was a very tough case.
Next time
Yes,
you
sir.
bring the summary and the
I mean-
recordings of the nerve conduction and all.
Now Ravichandran is here, sir.
She will have to have a mock examination. That was only a mock examination for her.
Yes, sir.
Good morning, sir. Shall I
Ravi-
proceed?
Presenting Ravi.
Yes, sir. Good morning, sir. My case is Mr. X, a 20-year male coming from Pudukkottai with the chief complaint of difficulty in using right hand for 3 years, sir. Difficulty in using left hand for 1.5 years. Thinning of right hand for 1 year. Thinning of left hand for 8 months. History of presenting illness. Patient was apparently normal before 3 years. Then he noticed weakness of right hand, which is insidious onset, gradually progressive. Difficulty in holding pen while writing and mixing food and a buttoning shirt, and difficulty in changing gears while riding bike. And the weakness progressed later. Patient having difficulty in holding objects and slippage of objects from the right hand. Weakness remains static for the past 1 year. The weakness aggravated by cold water exposure to the hand. Patient noticed a similar kind of weakness on the left hand also for the past 18 months. He noticed a thinning of right hand followed by left hand, which is 2 years after the onset of the right hand weakness. The thinning noticed over the palmar and dorsal aspect of the hands and the forearm also. The weakness is associated with flyness. There is no twitching of muscles. No difficulty in raising arm above shoulder. No difficulty in getting up from squatting posture. No buckling of knees or slippage of chappals. No difficulty in lift of head from pillow or roll over on bed. No history of any sensory disturbance over the limbs, trunk, face. No layer sign, no radicular pain, no pins and needle sensation. Able to feel close, hot and cold sensation. No cotton wool sensation on the sole while standing on the floor. No history of bowel bladder disturbance. Patient able to sense the bladder filling and able to initiate and evacuate urine completely. No urge or stress incontinence. No history of any forgetfulness, behavioral disturbance, or spontaneous cry or laughter. No history of smell disturbance. No history of blurring of vision, grouping of eyelid ablution. No history of facial numbness or facial weakness. No history of hard of hearing, tinnitus, vertigo. No history of swallowing difficulty. No history of head turning and shoulder shaking difficulty. No history of any difficulty in manipulating foot and mouth. No history of postprandial fullness or postural giddiness or palpitation. No history of unsteadiness and walking a narrow pathway or slurring of speech. No history of involuntary movements of lip, or no history of any difficulty in releasing objects from hand after holding for a long time. No history of fever, weight loss, or night sweats. Past history. History of heavy physical workout in the gym and repeated neck manipulation by himself, which is forceful passive turning and stretching of head whenever for the past 2 to 3 years. Which he stopped after noticing the weakness in the hands. That neck manipulation which he did on he himself doing with his hands. No history of any neck trauma, electric shock injury, toxin exposure. No history of any tuberculosis, HIV, thyroid disease, connective tissue disorder, or cancer, or chemotherapy. Personal history: patient is on mixed diet, occasional alcoholic and smoker, no substance abuse.
1 o'clock supply.
Family history: patient born out of 3rd-degree consanguineous marriage, no history of any similar illness in the family members. So summary, sir. 20-year-old gentleman present with a chronic progressive neurological illness in the form of asymmetric distal flaccid weakness of bilateral upper limbs, right more than left, which aggravated by cold exposure, with the wasting of both hands and forearm muscles without fasciculation, without neck, trunk, lower limb weakness, without sensory involvement, without bladder bowel disturbance, with the history suggestive of normal higher mental function, cranial function, autonomic function, cerebral function without involuntary movements, with the past history of frequent neck manipulation without significant personal and family histories. Symptom analysis and probable structures involved. So first possibility patient possible structures involved anterior condyles in the lower cervical cord and multiple roots in C8 T1 level and lower brachial plexus involvement, ulnar neuropathy or muscle involvement, which means distal myopathy. Sir, hello.
Why only ulnar neuropathy? Was it only the muscles of the ulnar supplied by the ulnar nerves, or the only muscles involved? Is it?
Yes, sir. He's having only medial aspect of the hand involved, sir, mainly.
No Horner syndrome.
Yes, sir.
Horner syndrome.
No Horner syndrome. Sorry. History-wise, not yes, sir. And examination also no Horner syndrome.
We are in history only.
Yes, sir.
Sorry, sir. Sorry.
Correct. So in other words, why then, if it was ulnar neuropathy, ulnar nerve distribution, why bring in muscle disease?
Sir, patient is not having any sensory disturbance, sir. Only
you have not utilized the symptom of cold and excessive neck manipulation here in the symptom analysis. If you have used it, the number of things would have come down.
Yes, sir. He's in history-wise, he's having neck manipulation behaviors. That history is the past.
We're looking for etiology. Now you are in anatomy only, isn't it?
Yes, sir.
There is a question whether it's a myelopathic hands. Chat box question. Okay, you proceed. I will come back to that.
Sure. Shall I proceed, sir?
Yeah, proceed.
So general
What did you think you tell?
Sir?
What did you think of the 5 things?
Sir, of the 5 things, most probably I'm suspecting anterior cells and motor radicals, sir. Because patient not having, sir.
What are the symptoms of anterior horn cell involvement?
So patient is having significant wasting, the thinning of muscles and weakness, sir, without any sensory involvement. So since patient is having significant wasting and pure motor involvement, I'm suspecting anterior cells the first possibility, sir. And the patient is having bilateral involvement. So that multiple radicals bilateral involvement is least likely compared to anterior cells.
Symmetric or asymmetric?
So asymmetric involvement, sir. Asymmetric involvement. Asymmetric involvement, it's a sequential involvement, sir. Right hand followed by left hand, which is asymmetric, and main involvement the medial aspect of the both hands, including forearm. No associated sensory or no other neck pain or radicular pain, and no other bladder involvement. No other significant history is giving, sir. Only motor weakness and wasting of muscles.
You still want to entertain all the things in the element.
Yes, sir. Patient having flyerless in the hands. There is no spasticity in the upper limb or lower limb also. His history wise is not giving any spasticity or cramps. And he's telling distal upper limb, both upper limb is feeling flacidness. Flyerless he is feeling, sir. He's telling patient history wise he's telling.
Okay, you proceed.
Thank you. General examination. Patient moderately built and nourished. No pallar cyanosis, citrus clubbing. Vitals normal. Head to foot examination. No craniofacial abnormalities. No hair loss, skin rash. No exophthalmos, enophthalmos. No cataracts. No neck movement restriction, webbing of neck. No hair, low hairline. No thyroid swelling. No palpable lymph nodes. No peripheral nerve thickening. All peripheral pulse fret normal. Genitals normal. Height 171 centimeter. Weight 65. Neck length 14 centimeter. Height neck ratio is 12.21. No short neck observed, sir. Nerve system examination, higher mental function normal, sir. And cranial system examination, olfactory nerve normal, optic nerve, visual acuity, color vision, field of vision, fundus examination, everything normal. Oculomotor, trochlear and abducens nerve, bilateral pupil 3 mm reacting to light, extraocular movements normal, no Horner syndrome on examination. Saccades, pursuit, convergence, optocoinate nystagmus normal. Trigeminal nerve examination, trigeminal nerve branch 1 and 2, 3, bilateral pain, temperature, discriminated touch normal, clenching of teeth, mouth opening normal, jaw jerk absent. Facial nerve examination normal, no facial weakness, vestibular cochlear nerve involvement normal, no hard of hearing or no significant abnormality, glossopharyngeal nerve and vagus nerve normal, gag reflex normal, spinal axis nerve normal, sir, head turning and shedding of fluid normal, hypoglossal nerve examination, the tongue bulk normal, sir, tone normal by palpation, power and protrusion normal, no, there is no asymmetric protrusion, there is no wasting, no wasting and no fasciculation and fibrillations. Spinomotor system examination, inspection, bulk, bilateral arm, thigh, legs normal, sir. Bilateral hands wasting noted, especially bilateral hypothenar wasting with relatively preserved thinner bulk, left hand more than right hand, and dorsal grooving of hands present bilaterally, finger drop present left middle and ring finger in the left hand, ulnar clawing present in the right hand, and forearm, bilateral forearm, medial and posterior aspect wasting with relatively preserved brachioradialis bulk, left forearm more than right forearm, which is oblique amyotrophy we are observing. This is the patient hand picture. This we can notice left hand more wasted than right hand, especially thinner hypothenor aspect is more wasted with relatively preserved thinner aspect. When patient is having that exaggerated abductor portion of the fingers due to adduction weakness due to the palmar intrasei muscle weakness, and patient is we can notice right hand is having mild ulnar clawing in the 5th and 4th digits. So shall I proceed, sir?
Next slide. Go to the next slide. What is there?
Sir, then the patient is having mid-arm circumference bilateral shape, and mid forearm circumference right 22 centimeter, left to 21 centimeter, 1 centimeter difference, and the bilateral thigh and the leg. There is no significant difference in the bulks. Tone, upper limbs bilateral, shoulder and elbow normal, bilateral distal hypotonia present, lower limb bilateral hip, knee, ankle normal. Tone. Coming to power examination, neck flexion extension normal, shoulder abduction, adduction, flexion, extension, internal rotation, external rotation normal, sir, by 5/5, and elbow flexion in supination 4/5, flexion in semi-pronation 4+5, sir. Then flexion in semi-pronation more stronger than flexion in supination. Extension is 4 plus by 5, sir. Wrist flexion is 4 minus by 5. Extension is 4 plus by 5. It's a flexion weaker than extension. Hand grip bilateral weak. Thinner group of muscle examination. Thumb flexion, abduction, adduction, opposition, bilateral weak. Hypothenar group of examination. Little finger flexion, abduction, opposition, bilateral weak. Lumbricus, metacarpal phalangeal joint flexion with proximal interflexion extension weak. Intrashape finger abduction and adduction weak in all fingers bilateral. Or lower limb examination, hip, knee, ankle, power bilateral 5 by 5, sir. Deep tendon reflex, biceps bilateral, biceps supinator jerk, triceps set bilateral 2 plus, supinator jerk elicitable, triceps set bilateral elicitable, sir. Finger flexor bilateral 2 plus normal, knee jerk 3 plus, ankle jerk 3 plus, sir. There is no pathological reflex present like Kaufman, Tromner, Wattenberg, bilateral absent, sir. There is no release reflex like palmomental and snout pout reflex. Superficial reflex, cornate reflex, conjunctive reflex, abdominal reflex present, sir. Abdominal reflex is equally present in all 4 quadrant. Chromatic reflex bilateral present, sir. Plantar reflex bilateral flexor response. Sensory system examination, bilateral touch, pain, temperature, vibration, position sense, cortical sensation bilateral normal. There is no evidence of dissociative sensory loss anywhere, sir. Extrapyramidal system examination. Patient is having only tremor in the hands in extended posture, which is polymini myoclonus observed bilateral fingers. There is no rigidity, no dystonia. Cerebral function test normal, sir, which is finger nose test, finger nose test, rebound phenomena, heel test, tandem wake, everything normal. There is no stance and gait ataxia. Spine and cranium normal, gait normal, sir. Other system examination normal, sir. So my probable differential diagnosis, sir, since patient is
first to localize the lesion. Where is the lesion? Site of lesion.
Sir, site of lesion. Patient is having low site of lesion is lower cervical spine, cervical spinal cord level, sir, with possible structure not anterior cells, because bilateral asymmetric involvement of the hands, distal weakness of the hands with the wasting, sir. And
when will you say spinal cord involvement? Spinal cord involvement straightly. When will you say?
Sir,
when will you say this patient is having spinal cord problem?
So since patient is having bilateral involvement with the, so if
usually
Ravichandran,
sir,
Ravichandran, sorry to button. Ravichandran,
yes, sir.
is this presentation a lower motor neuron presentation or an
Yes,
upper
sir.
motor neuron presentation, or both lower motor and upper motor?
Lower motor neuron presentation.
Then why do you say cervical cord?
Yes, sir. Anterior cells of spinal cord, I told. Anterior cells of slow.
Okay. Okay. What are the features then to say it's an anterior horn cell?
So, first feature, pure motor weakness, sir. That is the first point. Second point is patient is having wasting, significant wasting, out of proportion of the weakness, and there is no stiffness. And flyless is there, sir. There is no human signs like stiffness, sir. And but for favoring motor neuron anterior cells, there is no fasciculation noted, sir, with history and examination results. And the patient is having polymorphism.
Knee jerks are brisk.
Reflex intact, sir. Reflex intact with the wasting of muscles.
No, knee jerks, bilateral knee jerks are brisk.
Sir, yes, sir. 3 plus normal present, sir.
ankle jerk and knee jerk can't be same. You put it as 3 plus both.
Yes, sir.
What is the scale you have used? Ankle jerk used to be less, isn't it?
Yes,
When
sir.
you put the
For
3
this
plus,
patient,
we always
sir,
consider it is exaggerated or
yes, sir.
brisk.
This patient ankle jerk is brisk, sir. In examination, we got 3 plus.
The plantar was flexor.
Plantar flexor.
So you are sure knee jerk and ankle jerk are brisk.
Yes, sir.
What is the tone in the lower limbs?
Normal tone, sir.
No thickening
See
of
that-
nerves. No thickening of nerves.
No thickening is a general assumption I told, sir. There is no thickening.
The jerks being brisk is subjective. Okay, for you
Yes,
it may be brisk. I might call it normally brisk. Is it physiological brisk? Is it pathologically brisk? There are so many briskness. It's
Maybe
subjective.
patient anxious.
You'll have to take it with the other signs.
Yes.
Abdominal reflexes are present.
No,
Plantars are flexor.
Yes, sir.
Isn't it?
So plantar flexor.
And tone is normal. No clonus.
No weakness.
No clonus.
Yes. So it's purely a low motor neuron involvement of the both upper limbs, which is asymmetric.
Yes, sir.
Correct. Okay. So you said anterior horn cell. I'll bring out the same differential which I shared for Shraddha's case. Why not it be a pure motor nerve? Why not it be a pure anterior radical?
Sir, it's in pure motor neuron, the waist weakness more predominant than wastings. With reflex may be depressed in motor involvement.
Repeat. Sorry, repeat it.
No, sir, weakness more predominant than wasting in nerve pattern, motor nerve patterns. And nerve pattern weakness will be there.
Right, sir. Radic is asking about the radiculopathy.
Yes, sir. In radiculopathy, weakness will be predominant, waist and reflex will be depressed because of the wasting.
Here also, one of the reflexes you put only 1+. I think it was triceps. Is it triceps or biceps?
Triceps is 1+.
Usually triceps is it better elicited than biceps or
yes, sir. Usually
which is better triceps or biceps?
Triceps will be the better elicitable than the biceps checks.
So certainly if it is 1+, that is abnormal.
Yes, sir.
So the reflex is down. Of course, I'm not. The reflex can be down in anterior horn cell. It can be down in radical. It can, well, less likely with the nerve. Yeah. Okay. So what my point is, you can't be definite saying it's an anterior horn cell.
Okay.
Okay, continue the discussion. Now you'll have to say which neuropathy can present like this and what is not there, what is there, which radiculopathy can present like this, or which anterior horn cell disease can present like this.
So first possibility.
All three are possible based on the findings. Now proceed further.
Yes, sir. So regarding anterior horn cells, since according to his age and presentation, I would like to proceed with the Hirayama disease. And in the anterior horn cell segment, and then coming to radicular pattern, it can be a
no. Why do you say it's Hirayama? What is see, Hirayama has certain features. No, you should identify those features and say whether those features are here in this person before going to an entity, definite entity. What is Hirayama after all?
Sir, Hirayama.
I can say it's a spinal muscular atrophy. It's an asymmetrical spinal muscular atrophy. That is what Hirayama also is. Or monomilic amyotrophy.
Sir,
it's not monomilic, it's bimilic.
No, sir. Actually,
so terminologies differ. But yes, what is the distinctive feature which you have here to say?
Distinctive feature here is the ulnar predominant involvement. Sir, in SMA and monomelic variant of ALS, patient will have ulnar and lateral aspect of the hand will involve more predominant. But our patient is having medial aspect of the forearm and ulnar aspect of the...
No. We were talking about nerve involvement, root involvement, anterior horn cell involvement. When talking about anterior horn cell, you brought in Hirayama. Yes. I was asking what is the feature for Hirayama in this patient after your examination.
So the feature,
or what is the feature?
The feature for the patient.
Not being a radical or not being a nerve.
Yes, sir. That amyotrophic oblique amyotrophy. Patient is having brachioradialis, sparing of brachioradialis.
Something about cold you said.
Cold exposure, cold paralysis. Cold paralysis, history-wise. An examination is oblique amyotrophy.
You didn't. Yeah, that's what you should mention. What do you mean by oblique amyotrophy?
Sir, the oblique amyotrophy is the preservation of brachioradialis with the wasting of the medial and posterior aspect of the forearm. This is a relative preservation of brachioradialis because of the.
You mentioned. So, what did you mention about the power?
The power in elbow flexion in supination is 4 by 5, sir.
4
Elbow
plus.
flexion is semi-pronation is the 4 plus.
So what does that mean?
Flexion in semi-pronation, like brachioradialis power is preserved.
See, that is what you should bring out in the discussion rather than go to Hirayama straight away. So you give the points here. The points are it's an oblique presentation, you said, oblique wasting. Brachioradialis is more powerful than the brachialis. And then go ahead with Arun, whatever Arun said. And in addition, you mentioned about cervical manipulations. So these are the points you should bring forth. Okay, proceed.
Sir, yes, sir. Then coming to motor roots, that C8T1 motor, because patient is having distal weakness and wasting, we have to next to under consult. Then coming to motor roots, that in motor root, patient is having predominant ulnar aspect.
There is the weakness of the elbow flexors.
Yes, sir.
And
So right.
tricep jerk also is diminished.
Yes, sir.
Vijay wants to say something.
No, I thought he can leave out the other. He's fairly sure. Yeah, and he's brought
Why
out
are you continuing with 5-6 diagnoses till? That's what I think Vijay is trying to tell.
Yes, sir. Please don't continue with the ulnar neuropathy and other things now.
And
You-
even
you've finished
amyotrophic
already.
lateral sclerosis.
Yeah, that also is not necessary. You've already
sir.
brought out the points very well. for the-
Intramedullary.
Yeah, very well. He has brought out all the points for the Hirayama. So I think he can exclude the other possibilities here itself.
Only how you discuss.
Maybe substantiate things for Hirayama and you can go on.
Sir, the Hirayama, then that in this patient, since patient is having adolescent age, his age is 20 years. So that Hirayama is more prevalent in the adolescent age group. After the attaining the peak of
You
the
continue with age, onset, symptoms, examination findings and all.
Yes, sir, I'm continuing. Sir. The patient is having chronic, slowly progressive weakness, sir, with the adolescent age group after the attaining the peak of his growth. And the patient is having exclusive involvement of the distal lower limb in the ulnar aspect of the forearm and hand with wasting, sir, without any sensory involvement, with the polyminy myoclonus, with the relative preservation of the brachioradialis muscle in and without any flaccidity, without any involvement of the lower canine nerve and bulbar weakness or and lower limb involvement, and with the history of cold paralysis. So, and with the past history of frequent neck manipulation, so that with the in examination, without any involvement of the Horner syndrome and nerve system examination, no involvement of the sensory and other involvement with preserved reflexes and plantar bilateral flexor. So, most probable diagnosis Hirayama disease. With this background history and examination file.
Progression. Ravichandran, progression he told about
The
progression.
progression, sir, actually it's a slowly progress disease. With the left hand, it started with right hand, sir. After 2 years, that progress stopped. Then it's weakness static for last 1 year. Then this left hand is progressing now. So the asymmetric progression, which is slowly progression, it is not progressing beyond 2 to 3 years. And the static. Sir? Yes, sir. That progress, it's not progress beyond 3 years, sir. And with wasting and weakness without any sense involvement.
Why did he have multiple neck manipulations?
No, sir. Actually, he is going to gym. That in gym trainer used to tell that while doing neck manipulation, you can have that neck muscle, proper neck muscle, like that. He told us that they used to, like initially that his gym trainer used to do. Now later he used to do. Then he stopped after noticing the weakness and the wasting of the hands. He thought he afraid of, because of that he developed.
You also made a mention about some cold involvement. No?
Yes, sir. Whenever he gave history that whenever his washing mouth, washing face with cold water, or when taking things from refrigerator, washing clothes, he's feeling that weakness is aggravated and it's leaving after 1 to 2 hours. That he's noticed in last 2 years.
What does that tell us?
So that is a cold paralysis, sir, because of that wasting and that in the degeneration of this muscles and peripheral nerve, patient will have that sodium potassium channel inactivity will develop, sir. So patient will have sustained depolarization and muscle weakness will aggravate.
Exaggeration of muscle weakness.
Yes, sir.
Why is it specific for Hirayama? I don't know. It's not that I knowingly I'm asking. Why is it? I know it's there, but why is it specific for Hirayama? If you know it.
I don't know.
Okay, fine.
So shall I go to investigations?
So what is your diagnosis?
Sir, diagnosis.
You don't want 5+1 diagnosis now.
So my proper diagnosis is Hirayama disease.
Okay, proceed.
Yes. So investigation, hemoglobin normal, sir, and the liver function test, renal function test normal, fasting blood sugar, postprandial blood sugar normal, sir, electrolytes normal, ESR 12 millimeter per hour, serum CPK normal. Coming to nerve conduction study, sir. Here I got right ulnar and left ulnar latency velocity normal, sir. CMAP reduced both right ulnar and left ulnar, sir. Right ulnar more than left ulnar with preserved CMAP in the both median nerves. So I calculated the CMAP of abductor digita minimi, the CMAP recorded over the abductor digita minimi and the abductor pulse previous. Its ratio is 0.16 and right hand and 0.5 in left hand, sir, which is showing that reverse split hand ratio, sir. That is
very good study. Very good study, Ravi.
Thank you.
Good that you did it.
Yes. So that is more favoring of Hirayama, sir, since the reverse that normal split hand is in we are seeing in ALS. The reverse split hand is more favor of Hirayama, that we can rule out ALS this level, sir. Next.
Why is it more in favor of Hirayama?
Sir, that is patient is having ulnar involvement in the many ulnar aspect of the hand involvement.
Right. So thinner involvement you will get in ALS and hypothinner in
Yes,
Hirayama.
Yes.
Yeah. Right.
Can it be bilateral ulnar neuropathy?
Sir, so it can be, sir, but there is no sensory involvement. So sensory study is normal. There is no conduction block to tell demyelinating neuropathy. But one possibility is ulnar neuropathy we can keep, sir. Since only CMAP is particularly reduced without any sensory involvement, we can and relatively preserved motor now normal study, we can take it as a undergone cell.
What about nerve conduction velocity?
So velocity normal. Sir.
It's hidden here. If you say it's normal, right.
So I did a EMG study for the patient. Hello, sir. Sir, then, sir, I got EMG and EMG I got fibrillation with a positive shock wave I got, sir. There is no fasciculation and a large amplitude polyphasic motor unit action potential with incomplete recruitment I got, sir.
Ravi, you will have to mention which muscles. That is important.
Sir, we did in both hand abductor pollicis brevis and biceps and paraspinal muscles I did, sir.
Abductor pollicis brevis.
Abductor pollicis.
Abductor digita minimi and abductor pollicis brevis, both muscles we did, sir. And 3 muscles in limb we did, sir. Abductor digita minimi, abductor pollicis brevis, and biceps and deltoid also we did, sir.
You found these changes in all of these.
Sir.
You found
Because
the changes
you
which you
had
mentioned
No, sir,
in biceps and deltoid also.
This change I got only in this abductor digita minimis.
Okay. That would, no, because Professor Mehigandan asked whether it's ulnar. If you had found it in biceps also, then it's probably not in favor. That's why I was asking. Okay.
So this MRI we did, neutral position MRI we did, sir. In this, I noticed loss of the normal cervical lordosis with hyperintensity in the cervical lord at the level of C5, C6 within a T2 sequence. And we did that Hirayama protocol flexion and extension study. In flexion study, I can notice that forward posterior aspect of posterior to the cord, we can notice that dural ectasia with flow voids, we can notice and decreased anteroposterior diameter of the canal and compression of the spinal cord over the anterior vertebral body. Then notice, and in extension posture, we can very well see that flow voids and dural ectasia, it's getting disappeared in extension study. And in the transverse section, we got that decreased anterior posterior diameter of the cord with diffuse hyperintensity in the C5 section. So this is my the report given by the radiologist. In that we got the T2 hyperintense region seen in the spinal cord from C5 to C6 level. It is possible spinal cord edema. And flexion image T2 hyperintense region seen posterior dural ectasia from C4 to C6 level. Possibility of Hirayama disease they gives. So this is that. So we conclude with that EMG, MCS, and imaging studies with a clinical scenario. We could have concluded it's a Hirayama disease.
What is your treatment plan? You have not mentioned anything.
Yes, sir. I will tell sir. The treatment plan. Usually, patient is having non-progressive and without any pyramidal involvement. We have to go for hard cervical collar and restriction of neck movements. If we are getting and weakness progression, that actually the Hausen criteria, the Hausen classification is type 1, type 2, type 3. Type 1 is a classical pattern in the ulnar pattern of the hand and ulnar forearm. And type 2 is pyramidal involvement. Type 3 is proximal upper involvement. In this type 2 is more favor, we will go for surgical correction. Surgical correction, we have posterior approach and anterior approach. In posterior approach, we have to go for a discectomy, laminectomy, and fixation of the pedicles. In anterior also, you can go the discectomy with the fixation of the pedicles, so fixation of the disc. So in this posterior approach is more getting good favorable outcome and favorable surgical procedures. So in management, we can divide into non-surgical management, surgical management. So non-surgical management, hard cervical collar, restriction of neck movement. If patient not having any progression beyond 5 years, no asymmetric involvement with pyramidal involvement or pyramidal weakness. If patient is having pyramidal involvement with progression and severe weakness and possibility of rapid progression, we could refer to patient with neurosurgical intervention. We have to correct the spinal alignment and remove the dural ectasia and stop the progression of the disease.
Ravichandran, what is the pathology and pathogenesis of Hirayama disease?
Sir, for Hirayama, they explain 5 pathogenesis, the possible pathogenesis. First is dural dysplasia, spinal root dysplasia, ligament dysplasia, and epidural venous plexus. Epidural venous increased flow voids. In this, first this dural ectasia, sir. Because of the discrepancy in the growth of spinal column and the spinal cord, patient will have the decreased loss of attachment in the lower aspect of the dura. So it will cause dural ectasia. Because of the dural ectasia, while patient is flexing the neck, it will have a dynamic flexion of the spinal cord, which will compress the spinal column over the anterior aspect, anteriorly placed vertebral columns. So it will cause chronic hypoxia of the anterior consoles. It will lead to micro circulatory necrosis of the anterior consoles. Second possibility is root dysplasia. Because of the root dysplasia, posterior root is getting dysplasia. It will cause tension of the spinal cord while flexing the spinal cord. That is also one possibility. And ligament dysplasia because of the ligament dysplasia, patient having the loss of elasticity in the ligaments. That is also caused the compression, dynamic compression of the spinal cord. And because of the spine epidural fluids, that while flexing the neck, patient will have the diversion of the venous return to the posteriorly placed epidural venous plexus because of the dynamic compression. So relatively hypoxia, because of the diversion of the blood towards the posteriorly placed epidural venous plexus, relatively hypoxia developed over the anterior aspect, and especially anterior ham cell more prone for hypoxia, chronic hypoxia. So patient developing the anterior ham cell degeneration over the course of period because of the continuous chronic microcirculatory changes.
Ravichandran, what is the clinical significance of snake eye appearance in imaging, axial imaging?
In axial imaging, if you are seeing snake eye appearance, which means involvement of the anterior horn cells. So with the anterior horn cells, with this, getting degeneration of anterior horn cells will show T2 hyperintensity lesion in the T2 hyperintensity, which is we are seeing like a snake eye appearance. The patient may need a surgical intervention.
Ravichandran, if the snake eye appearance is there, patient
is on chronic course.
Patient will improve or patient may not improve. Prognostic aspect.
Prognosis, poor prognosis.
That is the in this patient. Is there any snake eye?
No snake eye appearance. We are not getting snake eye.
There is one question in the chat box, Ravichandran, which you probably answered, but you could answer it straight away. What they are saying is, the question asked is, ischemic anterior horn cell damage at C8T1 based on the clinical features from higher C5, C6 lesion on radiology. That is what has been asked. Clinical findings suggest C8T1 involvement, radiological findings C5, C6Y.
Sir, it can be because that
somebody has already answered that. Okay, Arun Kumar already answered. It's due to ischemic anterior horn cell damage of C8T1. Is that it?
Yes.
Is he right? Okay, that's
Yes,
answered.
Yes, sir.
Can you once again tell me about this cold-induced aggravation of paresis? I somehow missed it in between.
So pathogenesis.
Sodium.
Actually, because of the denervation in the peripheral denervation of the muscles, that sodium potassium channel in the neurons will get deactivated, which will lead to persistent depolarization of the nerves, which is causing transient weakness of the muscles.
Okay, thank you. Very good presentations, Dr. Ravi Kumar.
Thank you, madam.
Kudos to you. Both very nice cases, very well presented. Felt as if I was sitting in the Ramanujam auditorium.
Yes, thank you very much, madam. This is all because of you are my teacher, madam. You only teach us, taught us how to teach the PGs. All
different. You have all done well.
Thank you, madam. Thank you, madam. From VN sir and from
very
you, madam.
Nice.
Thank you.
VN sir, not me. VN sir only for me also.
Yes,
no.
This patient, what happened? Did you prescribe a hot color or you asked for a surgery?
So we advised hot collar. Since patient not having any pyramidal involvement, we advised hot cervical collar, and for regular follow-up, he's in regular follow-up.
Is it an absolute criteria? Pyramidal involvement, no surgery. Is it
not absolute, sir? That is the main criteria, sir. Apart from that, rapid progression or asymmetric involvement, also patient is having severe weakness, progress weakness, we have to take, sir. So we are taking in a regular follow-up, monthly basis, coming and meeting us.
So what are you assessing every month? How are you going to prove that collars are not working and you have to go for surgery? What is the criteria that you are going to use, and when are you going to refer the patient for surgery?
Sir,
what criteria? You are going to review him every month. What are you going to see? On what basis you are going to refer him for surgical fixation in a lordotic posture without any fusion or even decompression? What is the criteria for that? Are you going to wait for a pyramidal involvement? Or are you going to look for further changes in the spinal cord? When are you going to call a failure and go for surgery?
So in other words, these patients recover very well after surgery. So it is the right time that you refer the patient to surgeon.
Yes, sir. What did the surgeon say?
Vijayan, are you there?
Actually, we refer the patient to NIMANS, sir. this patient.
No, no.
Yeah,
Is
you,
Vijay there?
most of surgeons claim that, as Professor Yabian asked, don't refer him once a patient deteriorates. Even before deterioration, it is better to refer
Actually,
him.
yes, sir. We
And they
divert
recover
to
very well.
neurosurgery department in Niman's, yeah, to get their opinion and to regarding surgery is referred.
Because the prognosis is usually good in these cases.
If this
Make
patient
it,
is
sir.
going to progress, some of the patients, 75% of the patients stop progressing at 5 years, and some of them progress even beyond that. So now it is 3 years. You do not know whether this patient is going to stop progressing. And since he has developed card signals, and I think it is very difficult to practically have a hard color and do any work. Soft color is okay. So most of these patients, they don't do well with the hard color, and you'll have to end up in surgery. And the results of surgery are so good that people have started using doing surgery in most centers throughout the world, even as early as possible.
Yes, sir. Most of the people are sent for surgery, and surgery they recover very well. Yes, sir.
Yes, sir.
Yes, sir.
No, do you recollect the hot discussion which we had in Professor K.S. endowment when
Exactly.
Manivan, Professor Manivan and Vijayan had over the same topic when A.V. Subramaniam presented the case?
That too, Suresh was
very
sitting
hot
there.
debate which was going on.
And my only doubt is, do you include contrast for the cervical spine? Usually, you did not do a contrast for that.
No, sir.
Is it not necessary to include a contrast for this Harayama protocol?
So is it necessary to check the flow weights of the venous flow weights? You have to do, sir. But since patient we are getting with this plain image, we are getting the clear-cut diagnosis.
No. See, the anterior displacement dura is considered to be normal in 40-50% of the people, and the posterior space enhancement and the prominence of flow wide is supposed to be a little more specific for Harayamas, and so it is better to include a contrast, extension, flexion, posture of cervical spine as routine in Harayama protocols.
Yes, sir. Nowadays we are getting more bibrachial and Hirayama disease. How often you are getting, sir?
Very. I am working in Vellore, sir. We get patients from Bangladesh every month. At least 3-4 patients we get.
Even in the Tanjavur bibrachial, we are having more than 10 to 15 cases, sir.
Okay.
Madurai also gets that. Madurai also gets frequent cases. Yeah.
Yes, sir.
Yeah, interesting. Earlier it was supposed to be unilimb, but now of course more and more cases of bilateral involvement is coming up. Yes.
Thank you, sir.
Arun, sir.
We will conclude, sir. I think.
Yes, sir.
Sir, what is your opinion about surgery for this patient, sir? Because he has developed a spinal cord problem also, spinal cord lesion also.
If it is progressive, it has to be done.
Not
better prevent further progression.
Yes.
He's an young man. Better and it's we don't expect much of a problem in surgery.
Yes, sir.
Yes.
So my humble opinion is that surgeons usually welcome these cases, and
because good results.
My own relative is also a neurosurgeon, and he almost operated some 6 to 7 cases, and he showed that they have improved very well. So it's the right time. That too, he is a young person. I think he's the right case for surgery.
Especially when the cord signals are also abnormal.
Not there. Yes, madam. Yes, madam.
Sir, in general, the surgeons welcome any referral to them at the early stages because the results are invariably good. They'll be only happy to have them early.
Sir.
Yes, sir.
Sir, shall we close, sir?
Yes, sir. If you can decide and do it.
I profusely thank the 2 postgraduates and Professor Ravi Kumar, sir, for coming out with such a beautiful worked out cases, sir. I thank my teachers for reminding us of our previous days. Thank you very much, sir. I think we can close this session, sir.
And thank Dr. B.N. sir for organizing this every month.
Okay, it's my turn now. I thank Professor Ravi Kumar and the postgraduates of the Tanjavur Medical College Neuro Department for the very good cases and providing so much of discussion. I thank Professor Arunan for conducting the show, and I thank Professor Banu, Chitrambalam, Vijayan, Meghandan sir, for all taking active participation. And Chitrambalam, as usual, forceful discussions. You need to be here in the forum.
Sir, I
But for
especially
you-
thank Chitrambalam sir for his words.
ஆமா
Thank you.
அவர் இருந்தாதான் அது ஒரு ஜோஷே
Force.
இருக்குதுல்ல.
களை கெட்டுச்சு அவர் வந்ததுனாலதான்.
Yes, correct.
Thank you, sir. Thank you very
Okay.
much.
Thank you.
And thanks Sun Pharma for all the logistic support. And thanks
you, sir.
all the other participants who had taken part in the chat box by posing questions. Ramki had posted 3 out 4 questions.
Arun
I
Kumar.
thank all of them. And Arun, yes. And yes, sir.
Bye, sir. Bye. Thank you.
Bye-bye.
Thank you so
Pray
much.
for yellow, sir. Pray for yellow, sir. Thank you, sir.
Oh, hope so. Yes. The whole Chennai is praying, Arun,
Yes, sir. Yes, sir.
and including Professor Meghandan. He was discussing with me just before the start.
Yes, sir. We will win today, sir. Thank you very much.
Thank you, sirs. Thank you, all of you. Vasant, thank you, ma.
Thank you,
Okay,
sir.
thank you, sir. Thank you.